Welcome back to another episode of School of Airway. I was reading something on PubMed and I saw it. Standardization of extraglottic airways. Is it time yet? I think more importantly, instead of standardizing what device you have, is that you should have the device in your airway. In your airway box, airway bag, airway cart. For who? The patient you need to oxygenate. Alright? People have this misconception that these devices should only be placed for elective intubations, elective procedures, and they're not. They're designed for rescue oxygenation. Will it happen in your emergency room that you give too much of sedation during procedural sedation? Yes. You have to put one of these until the patient recovers, and then you can comfortably take it out. Alright? It's better than intubating someone and calling ICU for an intubation for a patient that you overly sedated or didn't predict how much sedation the patient was going to feel or react to for the dose that you picked. Alright? Now, standardization. Really, there's not one LMA in the world. A long time ago, when LMA was the only thing that came out, you had a BVM, or you had something that looked like an LMA. The patent wore off with LMA, and look at these wonderful evolved versions of LMAs. Right? No longer the LMA Supreme, now this is the LMA Protector. Right? Designed for intubation. If you get it in, a gastric suction. This is a less evolved version. This is the Aura I, and now there's a gastric port for the newer version that's called the Aura Gain by Ambu. This is the Air Q, designed for intubating. They call this part the port for the gastric blocker. It's really good draining the stomach. Right. The newer versions don't have the gastric blocker part, but has a novel concept called SP, and that you no longer have to inflate a cuff or pilot balloon. You put air in, it auto inflates the cuff at the interface of the airway, and if there's just enough, it inflates itself and against the pressures of the soft tissue at the glottic airway. And it auto regulates that when you exhales, it actually slightly decompresses, but enough that there's still a seal. Alright? No more over exaggerating inflation or causing mucosal trauma by overinflating this pellet. Each of these devices have their unique peculiarities and uniqueness, right? No more inflating a cuff with an eye gel, right? It's supposed to be so soft, right? It kind of melts or it seals itself to the glottic airway over time, right? Has a natural bite block built into it. Small port, really only designed for anesthesiologists, gas and liquids only, not for frijoles and rice pilaf, not for General Tso chicken and brown rice. Corn, yeah, right. All it takes is one piece of corn kernel and I'll clog this hole. Alright, that goes to this hole. How do I standardize this? I would not. And of all things, my residents and my trainees always ask, where's my LMA? Now, I probably would go the route of the intubating LMA, and which one? Time will tell. But the one I would use is this one because it's rigid, flexible, has a natural bite block. I've seen it best used in this device, but I would have to get a disposable air scope that mimics a fiber optic scope. But I have to, shell out $250 to $300 per piece every time I used it. But it would be interesting to use. But I don't think these devices are equal to the device that I've been using for many years, that the pre-hospital has been using for many years, the King LT. You get a patient who's already aspirated, already vomiting, in cardiac arrest, this is the device I put in. And regardless of what the studies that talk about overinflating, the device can lead to tongue engorgement and possible carotid artery and venous obstruction. This has been studied in pigs. I've yet to see a study that talks about it in humans, and this has saved more patients than any of these devices, in my opinion, in my ED. I'm kind of biased because this is very great to use for patients who've already aspirated, already vomited, and it's a crapshoot in that airway. Right? I need to suction, clean everything out before I go to intubate. But this will provide me a way of oxygenating just the glottic opening between these ports, and how to block off more additional aspiration into the glottic opening. All right, that space that it blocks off, and it allows for diversion of the gastric contents and suctioning. This is the device that I like. Biggest limitation in this device, you can't intubate through it. Not yet. You could blindly try to boot a bougie in and take it out and snake it over with the ET tube. But if you do that, you might as well play Powerball and not come into work tomorrow because you know you won. Alright? Or wait for what the guys in VBM have designed, is an intubating laryngeal tube version of this. Alright? The Germans evolved this device to an intubating version that will fit regular fiber optic scopes, not just pediatrics, and fit regular ET tubes. I cannot wait for that design to happen, because if that design happens, I will continue to use this device. Now, some people have been biased and only train on LMAs or things that look like LMAs, so their algorithms only include this. They always forget about the bastard son, the Jon Snow of airway devices. Alright? They forget about this device that works just as well. And in pre-hospital settings, this has been studying greatly. LMAs, less. And if it's been studied, I'm sorry, the outcomes are better with this, in my opinion. Alright? The paramedics have used this to great efficiency, success. Put end-tidal CO2 on it. They know if the patient has ROSC. I'm just telling you, this is not to take away airways from paramedics or ER doctors. It's to provide rescue oxygenation. Right? Before you have to pre-oxygenate them for intubation, to rescue them from continued aspiration. Right? Decompress the stomach. You bought yourself some time to do a surgical airway or intubate through the mouth when you have a chance. All right. So this idea about standardization of glottic airways, supraglottic airways, more important than any glide scope purchase, any bougie purchase, is a rescue oxygenation device. And I'm telling you this. It is very rare not to be able to intubate and ventilate someone, alright? aka oxygenate someone through a BVM. But should that happen, and it will happen in your career, all these devices probably a better job than just face mask. It's nice to have a backup when you fail on BVM, on ambu bagging the patient up. That should be standardization of care. Every cart, bag, airway kit should have some type of supraglottic device or extraglottic device for rescue oxygenation. Again, that is more important than intubation. More important than any McGrath red EMS version, or CMAC blade with the D blade, or King Vision, or AirTrack, or Glide Scope, regardless of what blade you have. Again, I hope people understand this. Okay? Thank you, and please come back to another School of Airway. Alright? I'm very passionate about this topic. I've unleashed the beast. Alright? Thank you.